Hello everyone, welcome to my channel Hub. Myself Dr. Jolsna, and this is our third session of Temporomandibular Joint Disorder and Management. So in our previous sessions we have completed discussing till the clinical examination, and there we discussed the history recording and also inspection, palpation of the TMJ as well as the masticatory muscles and also auscultation of the joint sounds. And coming to the next topic, that is TMJ imaging. So before getting into the slides, I request everyone to please do like and share my videos. And if you're new to this channel Hub, please do subscribe and support me. If you have any queries or feedbacks, you can either comment below this video or you can mail me at this mail ID. Coming to the imaging of TMJ. So because of the complex anatomy of TMJ, we need special imaging techniques, and the most important diagnostic advances in temporomandibular disorders have occurred in imaging techniques for the TMJ. And the basic one, that is the OPG, remains the most useful screening tool, and the plain radiographs that include specialized technique for TMJ like the transcranial, transpharyngeal, transorbital, etc. have been almost completely replaced by computer tomography for the evaluation of bony morphology and pathology of the joint as well as the mandibular ramus and condyle. Again, cone beam maxillofacial CT is a newer and faster technique with a lower radiation dose than the conventional CT. Again, the next one is the magnetic resonance imaging, that is specially for the evaluation of soft tissue abnormalities of the joint and surrounding region. So this MRI has become the gold standard for evaluating the soft tissue around the TMJ. So the anatomy of the joint and the position and structure of the intra-articular disc can be accurately visualized both at rest as well as in motion. And also it allows for analysis of the blood supply and vascularity of the condyle, and also for detection of pathologic accumulation of fluid within and around the joint. Next, arthroscopy. It is a minimally invasive surgical technique that allows direct visualization of the anatomy of the TMJ. So these are some of the TMJ imaging techniques. Next, we are going to discuss the management of some of the common clinically seen TMDs. So I'm going to briefly explain the disorder, the clinical features, radiographic features, and also the definitive as well as supportive therapy that's required. So here we are going to discuss the developmental disorders, articular disc displacement, TMJ arthritis and rheumatoid arthritis, subluxation, dislocation, ankylosis, and NPDs. So let us see one by one. The first one, the developmental disorders. So the embryonic development of TMJ is frequently disturbed, leading to many kinds of abnormalities that include condylar hypoplasia, condylar hyperplasia, neoplasia, etc. And we know that mandibular condylar cartilage is the center of greatest growth in the craniofacial complex, and so it's associated with the maxillofacial skeletal morphogenesis and also the TMJ function. Now, coming to etiology of these developmental disorder, it's mainly due to trauma that's affecting the condylar head and also genetic deformation. The clinical features include clinical asymmetry, and pain is just secondary to the structural changes. Now, the treatment aims to restore the function while minimizing any trauma to the associated structures. Next, coming to the disc derangement disorder. So mainly we are going to discuss the articular disc displacement, and this happens because of the abnormal relationship between the disc, the mandibular condyle, and the glenoid fossa. So we know that basically disc displacement is classified into disc displacement with reduction and without reduction. So here there is rotational disc displacement, which is characterized by an anterior or a medial or lateral position of the disc with respect to the ideal position between the condyle and the eminence. And the diagnostic criteria for temporomandibular disorders for the research and clinical purpose was updated, and that classifies the disc displacement into 4 groups, which includes disc displacement with reduction, disc displacement with reduction with intermittent locking, and disc displacement without reduction with limited opening and without limited opening. So here the first figure illustrates the normal anatomy of the TMJ, where you can see the articular disc interposed between the condyle and the glenoid fossa, and During the opening of mandible, we have already discussed the biomechanics of mandibular opening and closing in our previous session. And there we said that during opening, it is first the rotation of the condyle followed by translatory movement, and during translation, the combination of the disc morphology and the interarticular pressure maintains the condyle on the intermediate zone of the disc, and the thicker anterior and posterior bands of the disc forces it to translate along with condyle during mandibular opening and closing. So the mandible and the condyle moves as a single unit. Now coming to the second figure, here you can see the disc gets displaced but with reduction. So the disc gets displaced from its position between the condyle and the eminence to either an anterior or medial or lateral position, but it reduces on full opening, usually resulting in a click. So anterior displacement with reduction is actually defined as disc displacement in the closed mouth position that reduces to the normal relationship at some time during opening but with a click. And here often the patient will not have pain, and the mandible deviates to the affected side on opening until the click occurs and then returns to the midline. Now this situation may worsen and there may be intermittent locking of the disc, and then this intermittent locking progresses over time to anterior disc displacement without reduction, which is also called as the closed lock. So that is illustrated in the third figure. So this is a condition in which the disc is displaced from its normal position and it's associated with limited mandibular opening. So here the dislocated disc acts as a mechanical obstruction to the opening and translation of the condyle, and these patients have a marked decrease in mandibular opening on the affected side and is associated with pain. And this is the disc displacement without reduction, where the maximum opening may be limited to 20 to 25 mm. To the etiology and clinical features of disc displacement with reduction. So, this disc displacement with reduction is usually as a result of elongation of the capsular and discal ligaments coupled with thinning of the articular disc that usually occurs as a result of trauma, that can be micro or macro trauma. And the other causes include joint overload, again due to parafunctional trauma, and also orthopedic instability. The clinical features include joint noises, deviation of mandible to the affected side, loss of function or limited movement, and also occasionally a change in occlusion. Next, coming to the treatment aspect. So, the treatments for internal derangement can be divided into surgical as well as non-surgical options. But the general treatment goals remains the same, which aims at decreasing the joint overload, decreasing the pain and inflammation, improving the range of motion, and to restore the function, and also causative factors has to be identified and controlled. Now coming to the treatment of anterior disc displacement with reduction. So the definitive approach is to re-establish a normal condyle disc relationship, and here you can utilize the muscle relaxation appliance and also an anterior repositioning appliance. So the patient should be instructed to wear this anterior repositioning appliance 24/7 to reduce symptoms, and this will also prevent or minimize adverse occlusal changes. And as the symptoms resolve, patient can decrease the use of the appliance, and if the symptoms return after the elimination of appliance and if there is orthopedic instability, then dental therapy should be done to correct the condition. Now the supportive therapy, here the patient has to be informed about the mechanics of the disorder and the adaptive process that is essential for treatment. So here the patient should be encouraged to decrease loading of the joint. Softer foods, slower chewing and smaller bites should be promoted, and inflammation if present, NSAIDs should be prescribed, and also passive jaw movements will also help in this situation. Coming to the etiology and clinical features of disc displacement without reduction. So the etiology, the most common reasons are macrotrauma and microtrauma. The clinical features include pain as well as limited mandibular opening with normal eccentric movement to the same side and restricted eccentric movement to the contralateral side. Coming to the definitive treatment, so the initial therapy should include an attempt to reduce or recapture the disc by manual manipulation, followed by use of an anterior repositioning appliance. So the success of manual manipulation for the reduction of a dislocated disc depends upon three factors. The first one is the activity of the superior lateral pterygoid muscle, and this muscle should be relaxed in order to permit successful reduction. If it remains active by pain or dysfunction, it may need to be injected with local anesthetic before any attempt to reduce the disc. The second factor is the disc space. So the disc space must be increased so that the disc can be repositioned. And we have already discussed about the influence of interarticular pressure on the disc space in our previous session. And there we said that when there is increased activity of elevator muscle, the interarticular pressure increases and the disc space decreases. So this makes it more difficult to reduce the disc. So the patient has to be advised to relax and avoid forceful closing of the mouth. The third factor is that the condyle must be in the maximum forward translatory position. So the only structure that actively reduces an anteriorly dislocated disc is the superior retrodiscal lamina. So if this tissue has to be effective, then the condyle must be in the forwardmost position. So we have discussed about this retrodiscal lamina and the interarticular pressure in our previous session. So this is how the manual manipulation is done. Here you can see the patient is having limited opening, and before manual manipulation, ask the patient to attempt for reducing the dislocation without any assistance. So patient is asked to move the mandible to the contralateral side as far as possible, and from this eccentric position the mouth is opened maximally, and if this fails then assistance with manipulating is needed. And for this, first the thumb is placed intraorally on the mandibular molars, and the remaining four fingers are placed on the inferior border of the mandible anterior to the thumb position. And you can see the other hand is used to stabilize the cranium above the joint. Now, while applying the force, apply a firm but controlled downward force on the molars, and at the same time upward force is placed by the fingers. So, downward force on the molars along with upward force by the fingers, and this movement will bring the condyle downward and forward, which translate it out of the fossa. So once this manual manipulation is done, ask the patient to relax for 20 to 30 seconds, and then ask the patient to lightly close to the incisal end-to-end position on the anterior teeth, and after relaxing for a few seconds, open wide and return to the anterior position. And then an anterior repositioning appliance is immediately placed to prevent any clenching on the posterior teeth. So this is the technique of manual manipulation. Now, the supportive therapy for a permanent disc dislocation begins with educating the patient about the condition. Because of the restricted range of mouth opening, many patients try to force their mouth to open wider, and this can aggravate the intracapsular tissues, producing more pain. So, patients should be encouraged not to open too widely, especially immediately after the dislocation. And with time and tissue adaptation, patients will be able to return to a more normal range of movement, but this will take time. Also, the patients should be told to decrease hard biting, no chewing gum, and generally avoid anything that aggravates the condition. Also, gentle controlled jaw exercises will help to prevent the situation. And if pain and inflammation is present, NSAIDs can be prescribed. Coming to the surgical considerations, so surgery should be considered only when conservative therapy fails to resolve adequately the symptoms or progression of the disorder. And here the first one is arthrocentesis, which is the most conservative surgical procedure wherein two needles are placed into the joint and sterile saline solution is passed through lavaging the joint. So this is basically a technique to therapeutically wash the joint space with sterile solution. And this lavage is thought to eliminate much of the inflammatory mediators and breakdown byproducts that produces pain. Then next one is pumping the joint, wherein a single needle can be introduced to the joint and fluid can be forced into the joint space in an attempt to free the articular surfaces. And this helps to improve the success of manual manipulation for a closed lock. The next one is arthroscopy. So this is a technique wherein arthroscope is placed into the superior joint space and then the intracapsular structures are visualized on a monitor. And here joint adhesions can be identified and eliminated and the joint can be significantly mobilized. And here it improves the disc mobility and it cannot correct the disc position. Next one is the open joint surgery called as the arthrotomy. So variety of arthrotomy procedures can be performed, and when a disc is displaced or dislocated, the most conservative surgical procedure is the discal repair or plication. And during plication, a portion of the retrodiscal tissue and inferior lamina is removed and then the disc is retracted posteriorly and secured with sutures. The next one is discectomy, that is when disc is damaged and can no longer be maintained for use in the joint. So in this case, the disc is removed and it leaves a bone-to-bone articulation which likely produces some osteoarthritic changes. So another choice is to remove the disc and replace it with a substitute, that is a discal implants. So this may include medical celastic, Proplast Teflon, dermal and auricular cartilage grafts. So these are the different surgical techniques to correct a permanent disc dislocation. Next, let us discuss the degenerative joint disease, and here we'll be discussing about arthritis, which means inflammation of the articular surfaces of the joint. And there are several types of arthritis that affects the TMJ, which include osteoarthritis, osteoarthrosis, polyarthritis, etc. So arthritis is defined as the disorder of articular cartilage and subchondral bone with inflammation of synovial membrane. And this is actually the body's response to TMJ overloading. Now, the etiology include microtrauma, which results in overloading, and the articular surfaces softens and subarticular bone resorbs. The clinical features, it may be symptomatic or asymptomatic. Crepitation can be seen and unilateral joint pain that is aggravated by mandibular movement. Now, the radiographic features includes joint space abnormality, flattening or resorbing of the articular surfaces, disc perforations, and also Ehlers cyst. So, in this figure, you can see that the black arrows shows the Ehlers cyst. So, these are nothing but rounded radiolucent areas just below the cortical plate or deep in the trabecular bone. And if there is pain or discomfort from these cysts, either you can remove it with surgery or drain the fluid from it by aspiration. So, Ehlers cysts are also called as subcortical or subchondral cysts. Coming to the management, which includes definitive treatment, supportive treatment, and also surgical treatment if conservative treatment does not respond. The definitive treatment includes the use of an anterior positioning splint therapy and also occlusal equilibration procedures. The supportive treatment consists of relieving the joint stress and thereby preventing the TMJ overload, and the use of anti-inflammatory drugs for symptomatic relief and also physiotherapy. The surgical treatment includes arthroplasty, wherein we reshape the articular surfaces to remove osteophytes, erosions and irregularities, and also you can replace the temporomandibular joint with TMJ grafts. Coming to rheumatoid arthritis of TMJ, so this is a subclass of polyarthritides, and rheumatoid arthritis is a chronic systemic disorder of unknown cause, and about 50% of the patients have TMJ involvement in rheumatoid arthritis. So this is defined as a persistent inflammatory synovitis that leads to destruction of the articular surface and subarticular bone. The clinical features includes morning stiffness, joint sounds and swelling, and also tenderness in the joint. The radiographic features include bony erosion, flattening of the articular eminence, decreased joint space, and characteristic sharpened pencil head appearance of condyle or the mouthpiece of flute appearance. So in this figure, you can see the presence of scooped out areas of erosion in the posterior superior aspect of head of condyle that gives the appearance of mouthpiece of flute. Coming to the treatment aspect, so as the cause is unknown, there is no definitive treatment for this condition. The supportive therapy include pain reduction and also intra-articular corticosteroid injection. Sometimes the muscle relaxation appliance can decrease the forces on the articular surfaces and thereby decrease pain. Next is subluxation. So this is also referred to as hypermobility. The term hypermobility implies that there is radiographic or clinical evidence that the mid-axis of the mandibular condyle is translating beyond the peak of the articular eminence. So this is also called as self-reducible dislocation. So subluxation results when the disc is maximally rotated on the condyle before the full translation of the condyle disc complex occurs, and patients who have steep short posterior slope of the articular eminence followed by a longer flat anterior slope often shows tendency towards subluxation. And in subluxation joint, maximum rotational moment of the disc is reached before the maximum translation of the condyle. Therefore, as the mouth opens wider, the last portion of the translatory movement occurs with a bodily shift of the condyle and disc as a unit. And this leaves a clinically noticeable preauricular depression. And as the mouth opens to its full extent, a momentary pause occurs, followed by a sudden jump or leap to the maximally open position. And this is often followed by a thud sound rather than a clicking sound. And pain is not a characteristic feature of subluxation. Coming to the treatment aspect, so in subluxation, often the patient reports a locking sensation whenever the mouth is opened too widely, and the patient can return the mouth to the closed position but with a little difficulty. And here the definitive treatment is the surgical alteration of the joint, that is eminectomy, which reduces the steepness of the articular eminence and thereby decreasing the amount of posterior rotation of the disc on the condyle during full translation. However, usually the problem resolves with supportive therapy to eliminate the symptoms. So here the patient must learn to restrict the opening so as not to reach that point of translation which initiates the interference. And if this is not possible, then an intraoral device can be used to restrict the movement. So when you wear this intraoral device, it develops a myostatic contracture of the elevator muscle. Thus, it limits opening to the point of subluxation. And another method is physiotherapy. Next, let us discuss about dislocation, commonly referred to as open lock. So we have already said about closed lock, that is disc displacement without reduction. So normally when the mouth opens to its fullest extent, the condyle is translated to its anterior limit and the disc is rotated to its most posterior extent on the condyle. So in this figure you can see that on opening, the disc is rotated to its most posterior extent on the condyle as the condyle is translated to its anterior limit. If the condyle moves beyond this limit, the disc gets forced through the disc space and trapped in this anterior position as the disc space collapses as a result of condyle moving superiorly against the articular eminence. So there is collapse of articular space and the disc gets trapped in its anterior position and the retrodiscal lamina cannot retract this prolapsed disc. So we have already discussed the retrodiscal lamina in the biomechanics. So what happens is that normally when the condyle is pulled forward down the articular eminence, the superior retrodiscal lamina becomes increasingly stretched, creating increased forces to retract the disc. But in this case, as the disc space gets collapsed, the retrodiscal lamina cannot retract the prolapsed disc. And also, this condition is aggravated when the elevator muscles contract because this activity again increases the intraarticular pressure and further decreases the disc space. Coming to clinical features, often the patient comes to the clinic with inability to close mouth with the mouth wide open and there is anterior open bite and also myospasm of elevator muscles, and usually pain is as a result of an attempt to close the mouth. And this condition can also happen when the superior lateral pterygoid contracts during the full limit of translation, again pulling the disc through the anterior disc space. Now let us see how we can reduce a dislocated jaw. So the reduction is done by downward traction of mandible to release the spasm of masseter and also elevate the chin at the same time to keep the head in its position. When attempts are being made to reduce the dislocation, first the patient must open widely as if in yawning. So this will activate the mandibular depressors and inhibit the elevators. So we have already said what happens when elevator contracts, as it will further aggravate the situation. So we have to inhibit the elevator. So patient has to keep its mouth wide open as if in yawning. Now a slight posterior pressure applied to the chin will sometimes reduce a spontaneous dislocation. And if this is not successful, then place the clinician's thumbs on the mandibular premolars and molars and downward pressure is exerted as the patient yawns. At the same time, press the underneath of his chin upward and backward. So this will usually provide enough space to recapture the normal disc position. And to protect the clinician's thumb from the sudden closure of mandible, it is always advisable to wrap each finger with gauze. So this is how we reduce a dislocated TMJ. So the definitive treatment include reducing a dislocated TMJ, that is manually gliding the condyle back into fossa, and when this dislocation becomes chronic or recurrent, then you have to go for eminectomy, that is correcting the articular eminence. Then the supportive therapy includes prevention, which is the most effective method, and when the condition is recurrent, the patient is taught self-reduction of this dislocated jaw, and chronic recurrent dislocation is treated by surgical procedure. Next, coming to ankylosis, which comes under TMJ hypomobility. So here there is abnormal immobility of joint, and Kazanjian classified ankylosis into true and pseudo. So true ankylosis is due to intracapsular pathology, and pseudo or false ankylosis is due to extracapsular pathology that limits jaw movement. True ankylosis is further classified into bony and fibrous. So fibrous ankylosis is most commonly seen, which occur between condyle and the disc and the fossa, whereas in bony ankylosis there is ankylosis between the condyle and fossa. So already the disc would have been lost from the disc space. Pseudoankylosis may be due to muscle spasm, tetany, etc. Now, Sani has also classified ankylosis into 4 types. If you want to know more about it, please comment below this video. Coming to etiology, so the most common reason for ankylosis is hemarthrosis, which is secondary due to macrotrauma or previous surgery, infection, etc. The clinical features include the patient is able to open approximately 20 millimeter interincisally with restricted lateral movements. So even in ankylosis, condyle can still rotate with some degree of restriction on the inferior surface of the disc. So the patient will be able to open at least 20 millimeter. And this will again result in facial deformity, and no condylar movement is felt or visualized on a radiograph. Coming to the radiographic features of fibrous and bony ankylosis. So fibrous ankylosis, there you can see erosion of articular surfaces, the joint space narrowing and jigsaw puzzle appearance. And in bony ankylosis, the joint space is obliterated, degenerative changes can be seen in joint, and also progressive elongation of the coronoid notch. Coming to the treatment aspect, so if the function is inadequate or the restriction is intolerable, then surgery is the only definitive treatment available. And surgical intervention include gap arthroplasty, where there is complete resection of the ankylotic mass. Also techniques like genioplasty, distraction, osteogenesis are used to correct TMJ ankylosis. And this can be reconstructed with the placement of TMJ grafts. The supportive therapy, since the ankylosis is asymptomatic, generally no supportive therapy is indicated. However, if there is any injury to the surrounding tissues because the mandible is forced beyond its restriction, there may be pain and inflammation, and then the supportive therapy is called for, and it consists of voluntarily restricting the movement to painless limits. Coming to the final clinical condition that needs to be discussed, that is myofascial pain dysfunction syndrome, and this we will be discussing in our coming session. So I thank everyone who have watched this session, and if you have liked this video, please do hit the like button and also share this video among your friends. And please do subscribe Prostho Hub for more Prostho related videos. If you have any queries or feedbacks, you can either comment below this video or you can mail me at this mail ID. So it's a bye from Prostho Hub until our next session.